Hello, my name is Abraham Fatiha. Welcome again on Senior on KTV. I am a doctor of chiropractic and a nurse educator. Work as an assistant administrator and controller for a multi-specialty practice and urgent care center. In addition, I'm a case manager for managed long-term health care. So, first of all, I would like to explain to you about what is musculoskeletal pain. Well, musculoskeletal pain, musculoskeletal means is muscle, bone, ligament, and tendons. That's what's musculoskeletal. When you're experiencing a musculoskeletal pain, the pain mostly and up to 90-95% of the time related to movements. Well, there is for everything in this life pros and cons. Well, the good thing about it that every time you move, you experience pain in the lower back, neck, or shoulder, or knee. However, is not something of such a severity that needs to be really pursued in emergency level. Okay, they should be taken into the primary care physician to do some preliminary tests such as X-rays to rule out if there is any fractures. However, if there is a very big trauma that is really painful, well, an X-ray that will be performed in an emergency setting would be very useful to rule out fractures, dislocations, and or other severe abnormalities. Lower back pain causes. Let's discuss first what are the causes of the lower back pain. The causes of the lower back pain that is usually pre-existing factor. There is a pre-existing factor for the lower back pain. It's called degenerative joint disease or osteoarthritis, OA. Degenerative joint disease is a DJD. When the bones start to degenerate, the bone degenerate as a result of a disc, okay, that happened to dry up and thin in a height and gets down when the bones start to friction on each other. And when start to friction on each other, start to give some spurs, bone spurs. Well, this is a process that takes time. It's a chronic, insidious onset. It does not happen all of a sudden. It just wear and tear. It happens over a period of time. Disc problems such as herniation, bulging, and desiccation. Okay? And I will explain in details what it's all about, but we're just going in overview. Well, the disc in between the two vertebrae, as you see, the bone prominence, they have one vertebra, okay, that is right over there enumerated as L5, and on the top of it is L4, should be. And in between that, you see something is white color. That's called a disc. The disc. This is a disc, is a cartilage, okay, and it's avascular, does not have a blood supply. And what happened over time happened to be thinning and getting down in a height. Start to get shorter and shorter. That's why when an elderly people start to age, when somebody starts to age in an elderly, it's something, a natural aging process, okay? That's why people, when they age, they get shorter in height, okay? And when these discs start to thin and get down in height, the bone of one bone on the adjacent one start to get down and friction on each other and start to give a spurs. That's what is a degenerative joint disease. These problems, as I mentioned, herniation, bulges, and desiccations, there are many various types of disc injury. It's right over there, you see the disc. Well, the disc inside there is like a little cherry, and it's surrounded with surrounded with an annulus, with the fibers. Okay? When it's surrounded by fibers. When the fibers start to tear and the little cherry or the pulpus, it's called pulpus nucleus pulposus, okay, start to travel along that tear of the annulus. And when it starts to travel along the tear of the annulus, it will cause an impingement on the adjacent nerves. However, what's the good news about that the disc should be healed within 48 hours. It should be healed within 48 hours just because it is not vascular, does not have a blood supply. Okay? And this bulging is when the fibers that contain the nucleus pulposus, like a cherry, okay, right in the middle, okay, and surrounded by the annulus, which is fibers, like a fence-like, okay, start to bulge. The fence-like start to bulge. And when it bulge, sometimes, occasionally, can cause an impingement on the outside envelope of the spinal cord. Because the spinal cord goes through right in the middle of the canal of the intervertebral body. You see right over here, we see the back aspect. Right over here, if you see in the middle, you see those little holes? That are the branches that come out of the spinal cord. The branches that come out of the spinal cord. The spinal cord runs right in the middle, right after this bony prominence, okay? There is a spinal cord, and that spinal cord is enveloped, okay? And when it is enveloped, it gives branches off through those little holes, okay? So when the disc bulge, it gives an impingement. It gives a little bit of impingement on the spinal cord envelope, okay? You see those little branches in the green? Those are branches given off from the spinal cord. And you see those branches that are coming out of the root canal. It's called the root canal. Okay? When the discs start to get injured, it gives an impingement, a force that can cause some nerve pain. However, this is a very challenging field. If somebody experiences a pain, whether it's a pain comes from the nerve or comes from irritation of the muscle. Because when you have a disc injury, you must have to have a muscle injury. And the muscle are also innervated by a nerve. And when the muscle gets irritated, the nerves start to fire and gives pain, radiating pain. People tell you, oh, I feel pain in my legs, so I must have a sciatica. There is no such a thing right now in the 21st century, something called a sciatica. We do not have sciatica. Sciatica is really rare to find it these days. Okay? It's a pain that comes in from irritation of the muscle. So please do not get nervous when you feel pain in your lower extremities, on the thighs, on the hip, in the buttock, lower down to your thighs, and you know, don't get nervous, because these things is just only takes time to heal. Okay? Just as if you got a disc injury, you must have to have, as I said, a ligament and a muscle injury. Okay? When you have these things, a muscle and a ligament injury, it takes much more longer time to heal. That's why patients are recommended to undergo for rehabilitation, okay, such as chiropractic, physical therapy, okay, using heat and others. This all considered conservative therapy. Conservative, to teach the muscle. It's called a muscle education. Will we be able to bring the disc back or to put it back into place? That's a very big misconception. Of course not. You will not be able to put the disc back. That's it. Once the disc is injured, is done. It gets dried up, it heals, it gets dried up, and that will be it. On the long term, 5, 6, 7 years down the road, might experience a degenerative joint disease. because that joint is not healthy as it was before the injury. Okay? So trauma is one of the major causes. When somebody is trying to lift up something from the sitting position, they lift it up with the back. So you always want to use the muscles of your legs, such as the hamstrings or the quads. Do not ever use the force from the lower back, the back muscles. Some people put back pockets and they sit down. Some people sit down for a very long time. Some people experience a back pain or abdominal pain and they lay down for days. Immobility is one of the main factors that can cause a lower back, neck pain, shoulder pain, because those are muscles need to be moved constantly. What are the GI connection to the lower back? Well, of course, lower back pain, as I said, lower back pain is related to movement. However, lower back pain could be experienced not because of only muscle, bone, and tendon. It could be caused by a GI, by constipation, let's say, for example. When the colon is very constipated, is very blown up and constipated, it could lead into a lower back pain. So bowel movement at least once a day is very important. Also, in addition to that, some cancerous lesions cause severe, uncontrollable lower back pain, such as a prostate cancer, can cause a back pain. Prostate cancer that is not managed immediately can cause a severe lower back pain and uncontrolled that needs sometimes a morphine sulfate in a hospice setting. Or in an oncology setting, also they use a very strong opioid medications to alleviate this back pain. Is this back pain related to the cancerous lesion? Most probably yes. Is it related to a musculoskeletal? Also could be a possible. It could be both of them. It could be one of them primarily. But this type of phenomenon, a severe back pain that never happened before, it should be investigated right away. However, I would like to point out to you something that should be managed within a few minutes, not in hours. Severe sudden onset of back pain, lower back pain, along with abdominal pain, should call 911. Also, in addition, there are some people who experience severe back pain, but they try to manage it via taking analgesics. Okay? That needs an attention and needs to be pursued with the primary care physician, because to rule out other stuff than a musculoskeletal issues. Some musculoskeletal problems could lead into surgeries, but it's rare. Okay? And to my experience is not necessarily. The law and the rules would say, first of all, we have to try the non-invasive procedure, and then we go on to an invasive. Just like taking a medication, you always want to start off from a low dosage and then raise it up into a higher dosage. But if you start high, it's a little bit hard for us to get it down. Okay? Just I'm saying, just not only for a male who got a prostate cancer, also there are a phenomena among females who have a cervical endometriosis that are also a cause of a severe back pain. Those people who have a cervical endometriosis, uterus problem, lower urinary tract infection can cause a severe back pain. But those things, like as if there is an infection, it should be accompanied with a chills and a high fever and uncomfortable during the nighttime. Avoiding unnecessary procedures. I'm not saying that you should not have those procedures, okay? But some of them that you shouldn't have it at all. Some of them that should be reserved after a period of time. reserved up on trying different methods of treatment, okay? And if those different methods of treatment fail to reach the maximal goal or the desired goal of relief, then we can go ahead and we order it. For example, magnetic resonance imaging. It's really not meant to be for everyone upon experiencing a lower back or a neck pain. It's not. Because if somebody experiences a back pain, okay, that could be relieved by taking a low dose of analgesics. And when I say analgesics, is it Tylenol, ibuprofen, those are not contraindicated, and a low dosage of opioid upon the discretion of a physician, along with a sessions of physical therapy and or chiropractic for a 12 weeks period of time, that is fine. That is fine. Okay? So we just only can be happy with having x-rays to rule out any fractures, any dislocations, any abnormal soft tissue abnormalities. If there is any what I say by abnormal soft tissue abnormality, it could be like a mass lesion, like a cancer or tumor, or something, calcification of a soft tissue that is impinging on the nerves, or a constipation. Sometimes people don't know that they are constipated. They're having a bowel movement but are not as an effective, soft, and foam stool. So these things could be shown easily on x-rays. Trigger point injections. This is the only thing that really, throughout my clinical experience, did not find any reason for doing that. Trigger point injection is just an injection that is composed of corticosteroid and anesthetic, like such as lidocaine or Americaine, because Americaine has a very longer half-life. It stays in the system much more longer time than a lidocaine. And those trigger point, they just catch any muscle, just like this upper trap, and they inject it into there. Now, when you inject the muscle, you irritate the muscle. And not only irritate the muscle, you injecting a corticosteroid that make the muscle very weak. Very weak. It could rupture. If you do it on a tendon, it could rupture it. So I really don't see any rationale for doing the trigger point injections. I'll stop right over here. Nerve conduction velocity test and electromyography. Let's not talk about epidural injections yet. Nerve conduction velocity test and epidural and electromyography. Well, NCV is called NCV, and nerve conduction velocity, and electromyography is called EMG. So nerve conduction velocity test and electromyography, those are the tests that measures actually the velocity and signal that comes through those nerves that is coming out of the foramina. As you see, it is yellow. So what happened, they do two types of tests. It's a nerve conduction velocity. They will measure the signal transmission from the spinal cord to the muscle innervation. That's a nerve conduction. Okay? Is a nerve conduction, you're going to see how fast it goes comparing from one side to another. Okay? Versus electromyography is just, it happened by puncturing with the needle to the muscle and test how fast the signal can go from the muscle to the spinal cord, and is monitored on a monitor that gives some spikes and waves. That should be reserved after MRI results. If you have a positive findings on MRI and you strongly believe that the MRI findings correlated with the clinical signs and symptoms, you need to move on then with NCV and EMG upon the discretion of the practitioner. Because sometimes you just be fulfilled with those evidence on the MRI. Okay? Because electromyography can produce lots of pain to the patient. It's not really a simple procedure. It's very, very painful procedure. It is important, okay? It is important for the surgeon to operate. But if somebody is not going for surgery, there is no need for those tests. Epidural injection is being long time given. The side effect of epidural injection is infection. It is infection. I mean, you pushing a needle, a practitioner or anesthesiologist or an orthopedist or neurologist who push a needle right through. I'm going to show you one of the diagrams. So what they do, they just put the needle in, and as soon as they hit something, that a fluid come up out of the subdural, one of the spaces of the envelope, some fluids comes back into the syringe, they shoot down the corticosteroid and Americaine. What is so bad about it, okay, what does it do is actually you cause an impairment of the skin, okay, because you puncture the skin, you go through the muscle, you go through the close to the meninges and the envelope of the spinal cord. That could cause an infection. And when you're injecting something into the spinal cord, you have to be very careful that whatever you're injecting it is a sterile. Sterile, that means, is not even a clean technique. Is a very meticulous technique in nursing. That you should not even turn your back at the field. Okay? That everything that should not be touched at all. And in a sterile field, like it's in an operating room. So this procedure should occur in the operating room setting with a negative airway pressure. That's how meticulous you got to be. And the fluids that you're injecting into it got to be really sterile. Not a normal saline. It's sterile, sterile, sterile. Okay? It's much more cleaner than the ones with the IV, even. Okay? That's one thing. Another thing that I would like to say that really bothered me and bothered other practitioners, what is the reason for doing an epidural injection, is that if you can administer a corticosteroid via oral, okay, for 5 to 10 days and monitor the patient very closely, you could avoid having such a procedure because you can take it oral. Okay? So what is the reason for this? In addition to that, physical medicine and rehabilitation, family medicine, internal medicine, chiropractic, osteopath, all agreed on one point that chronic lower back pain comes from primarily the facet, not from the disc. If we go back into the image, and I will show you, you see those articulations right in the back where is the green and there is an articulation, it's called the facet. That's when one facet goes on the other one. One facet goes on the other one. You see it? They all put together like a puzzle on each other in the back. That's what holds one vertebra on the top of each other. That what holds each one on the top of each other. This is the problem of the lower back pain. Because those facets are encapsulated. What I mean encapsulated, those are true joint. True joint, that means they are filled with fluids, ligament is encapsulated, and a lot of nerve, lots of nerve. And those nerves called nociceptors. What's the nociceptors? Like a satellite. Okay? Satellite. This facet right over here, those facets, every level there is a facet. Every level there is a two facets actually. One on right, one on left. One on right, one on left. Whether you are on cervical spine or lumbar spine. Well, on the thoracic spine we're going to talk about it, but the thoracic spine is usually rigid. Okay? And we were born with it. We were born with the thoracic spine, and you only can feel the back pain in the middle back either because somebody has an infection, lower tract infection, pulmonophytis, or because it's a radiating pain comes from the neck or the lower back as a result of a spasm. Okay? But primarily, when we look at those facets in the neck and the lower back, and those facets are highly innervated. When they are highly innervated by what? By nociceptors and those satellites. And those satellites goes into the spinal cord, and the spinal cord will transmit them into the brain, whether on the same level or on the second level, or cross and go to the second level. So somebody have a back pain on the right, or the injury on the right, they feel it on the left. That is the trick of it. Because the injury could be on the right, but the person feels the pain on the left. Because the nerve conduction from one side goes into the other one and goes up. Sometimes it goes one level up and grows and goes to the other one. So there are multiple, okay, mechanisms that those disturbances could be transmitted. So those are a satellite. And when somebody is subjected to a trauma, or degeneration, those satellites start to fire so badly, and they transmit all this pain to the brain, and the brain will say, oh, okay, let's guard the place, and will start to give a muscle spasm. First of all, what we need to do, as I said, we go from non-invasive procedure to the most invasive procedure. Okay? And here, this is an educational recommendation, advice, is not to be as a substitute of going to your primary care physician and pursuing help, you know, from other specialized doctors who's in this field. Well, taking pain medication could include analgesia, which is anti-inflammatory, such as an Advil, ibuprofen. All ibuprofen comes in different brands. Advil, Motrin, etc. And it has been revealed that if you work with Advil in addition to Tylenol, if Advil is not contraindicated, along with Tylenol, because Advil is anti-inflammatory, it's only work on the outside. On the outside. If somebody have a contusion or pain on one area, should take Advil. And a Tylenol, because it affects on the brain. So if somebody has a fever, it's better to take a Tylenol, because the Tylenol is antipyretic, because it works on the central nervous system. It gets the fever down. Okay? So taking Advil and Tylenol had been revealed to be very effective and works in a synergy with each other. Synergistic. That means they work with each other. Wonderful. Sometimes it's up on the discretion of a primary care physician to give you a little bit low dosage of an opioid, okay, along with dose medication, anti-inflammatory, and taking conservative therapy as well. Conservative therapy is a physical therapy and chiropractic treatment to help you move on. Okay, so we can move the area, and we take pain medication for 10 to 15 days, so you can, you know, go ahead and you will get to cope with the conservative therapy. Along with that, you need to do some home care exercises. And one of the best home care exercises that are really easy to do is to stretch the buttock muscles. Stretching the buttock muscles is very easy. It's just putting a leg on the top of each other. Okay, cross your leg and put it on the top of each other and just bend forward slowly, little by little, and do it into the other side too. I'm not saying that you're not going to experience pain with those exercises. Well, when you experience the pain, you feel it in hip and a buttock region. Now, you can do these exercises if you don't have any hip problems. Again, okay? Because hip issues can give lower back pain. So, if you don't have any hip problems or knee problem, you can do this. You can you cross one leg on the top of each other and you raise it up, or you bend forward and you feel that pain. Hold it for 5 minutes and keep breathing. and do it like 10-15 times a day. That will help you out a lot, and that will increase the range of motion of the lumbar spine of your lower back so you can bend forward, along with taking the medications. In addition to that, you need to stretch the hamstrings. It's very easy. You just raise up your leg, okay? Or somebody help you out to do that and stabilize the other leg and raise it up a little bit, okay? And you feel the tension, but you stretch the muscle. The muscle will not get weaker, will not get smaller. But if you start to take a sedative life effect, it will make the problem unfortunately worse, because those are muscles that get a blood supply, needs to be healed, okay, and you need to be on the run and not disabled. Using the pillows between the thighs at nighttime and sleeping on the non-effective side, so the affected side should be up and the non-affected side should be down, it's a good idea, and having a pillow in between your two thighs, if that make you comfortable. Above all of those, heat is from heaven. Heat is the best for the lower back and the neck. Well, it's being said that using an ice, well, using an ice for the first 24 hours is not bad, but I would not recommend it, because heat is good. And some people can say, but there is a lot of inflammation in there. How come you don't want to use an ice? Using a heat is a superficial heat, a heat that can give into the muscle. Heat can give into the muscle to increase the blood supply into there, so to accelerate the healing process. And heat also can make you relaxed, okay? And can break up the muscle spasm. Now, using the heat, some instructions. Please do not lie on a heating pad, especially elderly people, especially people who got diabetes, especially people who are busy, and sometimes, please do not lie on the heat, because it can cause you burn after 15 minutes. And you always want to put a low heat, low to medium, never high. High heat can cause burn. You know, usually I would recommend to put like a 2 towels thickness in between the heat and let you heat the area and relax the region with increasing the blood flow into the muscle, so you can break up the muscle spasm. Always use 6 layers of towel between pads and skin. That's if you have a wet pad of heat, then you have to use the 6 layers of towels. But if you're using those commercial heating pads, please put it just only 2 towels. It will be okay, and on the low, and let it go, let it heat. Heating seats in a car is wonderful. Wonderful things. If you got that option and you can afford it, God bless. Go ahead. Do it. It's the best. Low heat is the best. No more than 10 to 15 minutes. Or when you feel like itchy, that's when your receptors, that's when the receptors of the skin get saturated. It will tell you it's enough. Don't do it again. Even when you're doing a massage and you're having a massager and you start to itch, stop right away. Itching can tell you that to stop. 3 times a day and often is a good idea. What is in the back of your pocket? It should be empty. Should be empty. No wallet, no cell phone, no cigarettes at all.